So we'll navigate in the next 15 minutes through the novelties that occurred at least in this latest year with regards to the treatment of pre-therapy and pre-surgery and post-surgical treatment in patients with muscle-invasive bladder cancer. These are my conflicts. So you pretty well know what are the advantages, theoretical advantages of administering neoadjuvant therapy with regards to adjuvant therapy. For sure, compliance is higher in general for this patient. The possibility to treat patient with a systemic therapy, to treat a systemic disease, which is the T2N0 bladder cancer, with a systemic treatment, so maybe with the right treatment since the very beginning. The possibility to grow up with the knowledge, on the biology of the disease by being able to match the post-therapy and pre-therapy tumor for biomarker discovery and to linking the biomarkers to clinical efficacy. The possibility of having the bladder in place with additional biomarker data, for example, looking at the urine tumor DNA when monitoring the disease, not just the ctDNA. So a lot of possibilities in clinical trials. For sure, there is still uncertainty, a bit of uncertainty for a small patient population with a high risk feature, with more aggressive disease, presenting with symptomatic disease, for which maybe radical cystectomy up front is still an opportunity not to avoid or not to miss maybe any residual possibility to have a long-term disease control for the treatment. And of course, adjuvant therapy, adjuvant immune therapy as well as adjuvant chemotherapy have the similar pros and cons that have been discussed for decades in bladder cancer. The typical patient presenting with muscle-invasive disease is shown here, a young female with strongly an aggressive muscle-invasive disease with a borderline renal function and a 40% degree of squamous cell component into the bladder tumor together with the urothelial carcinoma component. So what is actually available for this patient, this typical patient who is formerly, let's say, ineligible to cisplatin-based chemotherapy? The data for pure neoadjuvant trials, so trials, phase 2 trials providing only the neoadjuvant, the preoperative course of treatment, short course of 2 or 3 courses of checkpoint inhibition prior to radical cystectomy are summarized here. Very much similar, regarding the primary endpoint of these studies, the pathological complete response rate or pathological major response, nothing major, no major discrepancy between the checkpoint inhibitors, But again, here we are dealing with the short-term endpoint, But what about the long-term exposure and the long-term safety and efficacy of this drug? We have very limited data, from these phase 2 studies. We have updated recently the 5-year projection of PURE-1 administration, 3 course of pembro administration and radical cystectomy. The DFS curve and the OS curve looks quite promising, at least for the all-comers. The other good thing is that the signal related to the association between pathological complete response or pathological response, depth of response, and outcome of this patient is still on the same line of chemotherapy information. So this is a good point that we will discuss at the end with regards to the meaning of pathological response after non-chemotherapy or not only chemotherapy neoadjuvant regimens. Besides immune therapy, let's open up a short window on what is going on in terms of targeted therapy, for example. And Spain is contributing patient in this academic study with Italy, France, and UK in a Neoadjuvant study, which is an academic study providing erdafitinib or erda and cetrelimab checkpoint inhibition to parallel cohorts in patients presenting with MIBC with any kind of suitable FGF receptor 2 or 3 genomic alteration. So we will see what the feasibility and the data will look like in the near term. And we also have initial data from phase 2 studies providing ADCs various types of ADCs, EV, SG, or the combination, the latest data with the combination of DV and an immune checkpoint inhibition from Chinese colleagues, showing very high rate of pathological complete responses or pathological downstaging. So again, here there is an opportunity that is showing up. But what regards to perioperative therapy, so actually the big studies are targeting the entire space of treatment of this patient. So the triple course, the triple period, the neoadjuvant period, surgical period, and the adjuvant period. This is a summary of the ongoing phase 3 studies. You know pretty well what is what are the data that have been disclosed from the Niagara study. This is a study, and these are studies for cisplatin eligible population. So with the chemotherapy backbone, adding on chemotherapy backbone with a checkpoint inhibitor before therapy, and with a tail of maintenance of adjuvant checkpoint inhibition in the adjuvant period. The Niagara study, you're pretty much familiar with this with regards to the design of the study, to the patient population, and to the primary outcome. I would like to focus today on what I have discussed previously. What are the main points when projecting ourselves to the next avenue or trial? So PCR is prognostic for sure from this trial. This is an established surrogate for the outcome in MIBC. The contribution of adjuvant durvalumab, is still unclear based on the design of the study, and we will see, looking at the entire spectrum of studies ongoing, what is going on. But we cannot still disconnect the contribution of the adjuvant tail, and there is no, at least for the moment, clear prediction for benefit for checkpoint inhibition addition. What is good is that data from recently disclosed at the ASCO meeting from the ctDNA circulating tumor DNA analysis from Niagara show that ctDNA baseline or ctDNA clearance post neoadjuvant therapy is clearly prognostic. What is interesting to me, to looking at the ctDNA data, is that we were able to quantify a little bit the contribution of a critical part of this paradigm, which is a surgical part, which has become the surgical part, and also the role of the urologist in this path. So. Are we allowed, or how is safe to remove the block of the surgical therapy? We will hear from Matt what is the projection in terms of clinical trials. But when looking at ctDNA, at least, you see that there is a contribution of cystectomy over the entire success of the story. And what if TURBT is put instead of radical cystectomy? We don't have data for either ctDNA or clinical data in this kind of path. But it's an important part because cystectomy is at the center of the involvement of the interest on when envisioning the future of the next generation trials. We have trials for cisplatin ineligible population, comparing checkpoint inhibition or inhibition combination with the standard of care surgery. What is interesting to me is not registrational trials, these are phase 2 studies, just putting the hint of the possibility of treating muscle invasive patients, so not just the patient that Felix provided you in the previous lecture, T1 or CIS patient with intravesical therapy, but maybe select patient with T2 disease or T3 disease with intravesical therapy. This is true for TAR-200, the intravesical gemcitabine releasing system on the left-hand side, or the anti-adenoviral therapy on the right-hand side with the cretostimogene, which is still an intravesical therapy. Both of these options combined with the checkpoint inhibition. And if you look at the pathological complete response rates, this study provides a possibility of raising a little bit the bar of therapeutic success when looking at the path CR rate instead of pure systemic therapy trials. So what is the definition of success? We don't know. We are still unprepared, honestly, and I'm fully unprepared to answer the question of what is actually the success in this patient population. I wonder whenever the patient asks me what is the success for my disease. For sure, it's the cure, but it's not just the cure likely in the near future. So success for sure is survival, and these, all the trials of perioperative therapy should have survival as the endpoint, as the major endpoint, you know. But today, the success for the patient side is something different, you know. So it is due to a focus on quality of life, toxicity, possibility of sparing the bladder, we will see. So it's not just being cured in a curative setting like MIBC. And a pathological response rate still is important, and we are a bit low the bar for the success, which I think is at least 50% CR rate in the neoadjuvant trials. Adjuvant immunotherapy is also pretty well known with regards to the nivolumab trials. This is the latest update, corroborating the two labels, you know, from the two transatlantic labels of all comers, of PD-L1 positive patients in US and Europe. We have biomarker data from the 274 that will be published soon, pointing on the pre-existing immune activity and immune infiltration as a potential factors for predictors for adjuvant nivolumab benefit. So here it comes the question as to whether the addition of nivolumab neoadjuvantly may shape a little bit the tumor microenvironment and portending more benefit in the adjuvant setting also, when thinking, for example, that CD8 infiltration, for example, was not predictor in the adjuvant nivolumab trial of benefit with nivolumab, and maybe become predictive with the addition of a neoadjuvant part. We don't know. So there is a story with regards to immune therapy-related biomarkers that may be influenced by adding a short course, preoperative course of immune therapy. This is the same consideration that applies or may apply to the Ambassador study. We don't have today biomarker data from the Ambassador study. We will see if the same features will look like, will be applied in the Pembro story. And we do have the pretty well-established ctDNA story here for possible patient selection. There are the two trials. One is on the left-hand side, in Vigor 11 has been concluded. One other trial led by Matt on the right-hand side, the modern trial in the US is still ongoing. So we'll see if we will be able to shape a little bit, at least looking at the adjuvant part only for immune therapy, the possibility of selecting the patients. When trying to generalize a little bit the story of perioperative trials in solid tumor oncology, unfortunately, with very, very few exceptions, we are struggling against all the same limitations, you know, because most, if not all of these trials have been designed for registrational purposes. Registrational purposes are not 100% overlapping with science purposes sometimes, or fully patient benefit purposes, you know, fully science purposes, you know. This is the reason why we are struggling here against the fact that we cannot quantify, looking at the readout of the major trials, what is the contribution of what the patient, what is the patient best suited for adjuvant immune therapy, what is the contribution of the two components. We don't know, because we don't have the right design to answer this question, with the only exception maybe of melanoma trial, comparing pure neoadjuvant or perioperative immune therapy with regards to the surgical part, which is at the center, you know. So this is a consideration that applies in general and involves in general all the other colleagues that are dealing with the perioperative space. Unfortunately, we are not in this kind of situation in bladder. Like this one for MSI high tumors, receiving immune therapy, getting this kind of complete responses, you know. And for sure, there is an opportunity for treating all comers neoadjuvantly, you know, maybe sparing a surgical part. There is a small urothelial carcinoma component in this basket study, recently published in New England Journal of Medicine, sparing the patient, or the vast majority of the patient, the surgical part, you know. But we are not shaped similarly well in GU oncology, at least in bladder cancer, to be able to provide this kind of grafts. So in conclusion, PCR is prognostic across the tumor types in most of the tumor types when dealing with perioperative neoadjuvant and adjuvant therapy, immune therapy trials. lower risk of patient presenting at the time of cystectomy or the time of surgery suggests that there is a contribution, a clear contribution of neoadjuvant part. The decrease in ctDNA is able to quantify today the contribution of radical cystectomy in this path, but there are so many questions again that are still open. PCR meaning in the context of non-chemotherapy only drugs. What is the prognostic difference in the PCR with regards to different therapies, and what is the contribution of bladder sparing approaches in this kind of, or safety in this kind of path. And then lastly, applied in particular to bladder cancer, there are considerations that apply to the adjuvant setting when dealing with the possibility of preventing patients to access EV-pembro, for example, frontline when they develop metastatic disease. So these are considerations that will change, at least in a projection of 6 months, 8 months, with the newer perioperative therapy trials with EV-pembro or other similar situation. But today, there is still a concern with regards to the possibility of avoiding or preventing patients to access further therapies in this sequence. Thank you very much.